morning and welcome to the next in our series of presentations for the Madison County Heroin Task Force. I'm going to open our meeting this morning with a very sad statistic that I just received from the coroner's office. As of today, in Madison County, we are now up to 37 overdose deaths for the year. 20 of those are heroin overdose deaths, and 16 are believed to be prescription painkiller overdose deaths. And that's why we're here. We have the good fortune of having a very interesting and topical speaker today, Mr. Randy Malin from the Illinois Prescription Drug Monitoring Program. He's the clinical director and a resident of Madison County. And we're fortunate to have him to come today and inform us, educate us about the Prescription Drug Monitoring Program. And I am very interested to hear what he has to say and how we, as people interested in this, people in law enforcement, people in the community, knowing that the prescription drugs, prescription painkillers are truly the root of the evil that we're trying to rip out. This is important information for us, and I'm very thankful for Randy for coming today. And but prior to his presentation this morning, I do want to give a moment to Ashley Searing so that she can come down and talk to us about upcoming presentations on the Heroin Project.
Hi everyone, I'm Ashley Searing, and I'm one of the directors and producers of the Heroin Project, which is a documentary that you may or may not have heard about. We've had a couple of screenings so far, but I just wanted to bring two upcoming screenings to everyone's attention. The first one is on June 24th, which is a Wednesday at 7 p.m., and that's at the AMC Theater in Edwardsville. The second one is on July 22nd, which is also a Wednesday at 5 p.m., and that's at the Tivoli Theater on Delmar in St. Louis. And the documentary is about an hour long, and at the AMC screening, we're going to have a local drug coalition there that's there to hand out like resource material and answer questions. And we'll also have people from the film at both screenings just sort of talking about the film itself and sort of their own experiences. So you're all invited. The AMC screening is free and open to the public. The Tivoli screening is $12, but that's also open to anyone. So you're all invited and you hope to see you there. Thank you.
Thank you, Ashley. I really recommend for anyone who hasn't seen it yet that you see this. It's very telling, and it really hammers home the problem that we're facing. So without further ado, I introduce to you Randy Malin.
Thank you very much. What's rather interesting is Illinois has had one of the longer operating prescription monitoring programs in the nation. It originally started out as a law enforcement tool located within state police. And over the course of the following decades from its inception, it has been passed through numerous hands. I inherited it with the reorganization in 1997-98 of human services departments within the state government. As a clinician, when I first took a look at it, the operational entity of it, I knew I was in trouble, because we were actually manufacturing triplicate prescription pads and then selling them to the doctors. A third copy came back at the end of 30 days, and there was a team of Intrex operators who would sit down and attempt to create an electronic file. At that point, the maximum number of prescriptions that the state was tracking was 299,000 a year. When I started delving into the operational integrity of the program, I found that they were 6 months behind in doing any entry. So basically what we had accomplished was an impediment to good, active clinical care, because correspondingly, we found that less than, well, I'd say less, it would be approximately 50% of all prescribers who could prescribe for Schedule II narcotics were not even licensed to schedule. They didn't want the oversight. So consequently, less clinically efficacious drugs could have been being prescribed in place of more clinically efficacious. What we attempted to do was to reach out to every clinical organization that represents individuals that could either prescribe or dispense controlled substances and bring them together and collectively design a program that was of clinical nature, would be advantageous to clinicians to use proactively, and to continue to monitor and provide oversight with regard to evaluations of quality of clinical care. So what we're going to do is we're going to take a little time, and I'm going to give you a very quick overview. What I brought here as a demonstration, this is everything that affects the Controlled Substance Act, including the administrative rules that were just passed in March, and House Bill 1 that was just passed and is waiting signature. There are some very, very major changes that are coming. So, ostensibly, what we created was a data warehouse. As I said, under the old triplicate prescription program, we received copies, hard copies, every 30 days, and then attempted to get it indexed into an electronic base. Anyone want to take a guess at the maximum number of requests for reports we received from law enforcement during this time frame? Just a wild guess.
1,000.
Pardon?
1,000.
12.
12.
12.
Just 12.
Just 12. You want to take a guess on how many successful prosecutions happened against a errant prescriber from, oh, say, the previous decade and a half? Yes, one. Yeah, kind of. As of December 2014, we had undertaken 1,300 reports. Some from law enforcement, some from prosecuting attorneys, some from coroner's requests. While I can't give you an actual number of individual physicians and advanced practice nurses or mid-level practitioners or pharmacists, I can tell you we were eminently involved in every activity that was undertaken by DEA, by DPH, Department of Professional Regs, and quite a few of these individuals actually no longer have a license to practice. So, prescribers of controlled substances, we collect this data basically through the dispensers, because what has happened, originally when I inherited this thing and our advisory panel came together and we put together the initial move to electronic collection of data and utilization, we decided, well, more frequently that we get this information, the more proactive we could be. So we moved from once a month to twice a month. And that was initially on Schedule II drugs only. In 2007, Illinois had their senior senator, actually was the chief sponsor of what's referred to as the NASPR bill, which is the National All Controlled Substances Bill. So we went in 2008 and expanded the scope of our authority to collect information to include all drugs that are scheduled. So we exponentially expanded this thing. When we implemented this, we suddenly ballooned from a maximum of 299,000 prescriptions annually. We're just under 19 million annually, and collecting on about 4.1 million citizens of the state. So we have quite a bit of data that we have to be extremely careful in how we use. We fall under HIPAA guidelines. Also, if individuals have been seeking drug therapy, they also fall under 42 CFR. So we have to be very, very cognizant of individual patient health information. We also expanded and provided access to acute care hospitals, specifically allowing them to enroll in their emergency departments, and we received significant communications from emergency room doctors about how this helped them choose a different approach than what they were originally thinking, because they were able to identify that the individual had been on other medications that would have been interacted adversely with what they were planning to use. It also gave them an opportunity and a tool to use to see whom that patient had last seen, and to contact that clinician or that pharmacy to get a better picture of the medication profile of the patient as well as their health history. And last but not least, we do have in Section 318 on confidentiality the criteria on how law enforcement can approach us and ask for access to information. So, how about going over some stale statistics? So if somebody falls asleep next to you, wake them up. From 1999 through 2012, according to the CDC, there was a fourfold increase in the number of prescriptions being written for opioids. What is interesting to know is that from the same time frame in Illinois, it was only increased by 43%. When you look at the fatal poisonings, while national was sixfold in 3 decades, ours was closer to twofold. Still too much, but significantly better than national average. Non-fatal opioid overdoses with emergency department visits doubled from 2004 to 2008. We saw about a 1.5 increase. This is the most important piece of information I want you to take from here. That opioid overdosing and opioid adverse usage is a complex phenomenon. It covers both the prescriber, dispenser, and the patient. What happens, inevitably, it's an individual who has either been injured and put on these drugs who happens to like the feeling they get when they're on the medications, especially when their main level of original pain has started to abate. Unfortunately, based upon modern marketing, we are constantly being inundated with the thought process that if I ache or I have a discomfort, take medication, take a pill. No, that's the wrong idea. Even aspirin will kill you. What we have to do is re-educate the general population and have a very healthy respect on what this pharmacology can do, both beneficially and adversely. Also, as we move toward utilization of the use of naloxone in overdose, we're going to have to take the time to educate the loved ones that are concerned about the individuals that are abusing either opioids or heroin. Because if they use a quote-unquote rescue agent, don't expect that individual to come back and thank you. They're going to be upset with you no end because you ruined their high. Also, you're going to have to expend the effort to convince them they also need to go to an emergency department for further observation because a second or a third inoculation may be needed. In the July version of 2014 of Vital Signs, which is put out by CDC, it was interesting to note that Illinois was 50th in the best possible way with regard to the number of prescriptions written per 100 population for the high potency opioids as well as the long-acting opioids. In total, relative to prescription opioids, Illinois ranked 43rd from all states and all U.S. commonwealths. We're doing that on a budget of $600,000 a year. Our neighbor to the south, Kentucky, has $2.99 million, and they have a much higher utilization rate. What's also interesting, though, is that we rank 34th for benzodiazepines. That happens to be a class of anxiolytics that take away the anxiety, but unfortunately, if it's combined with the wrong types of opioids, can lead to CNS depression and death. And it could be the very first time. When we started moving to electronic collaboration and collection, we reached out to the federal government, a Harold Rogers grant that would allow us to undertake designing, developing, testing our data warehouse. Well, what was interesting is after a while, the feds started asking with regard to our expenditures, how many 661s were we seeing? And we started asking questions, what are you referring to as 661? That's 6 prescribers, 6 dispensers in one 30-day period. Now, I don't know how anybody could do 661 because it's hard enough for me to remember and to schedule my twice-a-year visits to my primary care. One of the things we did when we designed this entire program is not only are we capturing the patient's name, their address, their date of birth, but we're also collecting the information on the pharmacy and the prescriber and the method of payment. it becomes pretty interesting when you start looking at some of these and you see that the individual may be obtaining some of the medication using insurance as a payment, Medicaid as a payment, and interdispersed is cash payments. Normally at a different dispensing area. Anybody want to take a guess at the most frequent flyer for a 12-month period that we ever found? $63 prescribers, 58 dispensers. My guesstimate is this individual was bringing in about $7,200 a week. Pure profit. Because most of it was being paid for by third party. What this represents is in 2008, when we combined the 661 and started tracking it, and started giving lectures to our colleagues that were prescribing these drugs, we see it continuing to drop. This represents the 6 pharmacies, this represents the prescribers. And oh, by the way, it's not just physicians. It's physicians, dentists, optometrists, mid-level practitioner nurses, and physician's assistants. Ostensibly, where the primary care doc is supposed to be coordinating care. In some cases, they are doing a wonderful job. In some cases, not so good. What's interesting about this 661 is the fact that if House Bill 1 is signed into law, it's going to drop to 331. What I currently am responsible for doing is, on a quarterly basis, we run a report to identify the 661, and I literally take the list and I go through looking at what's the distance from that patient's home to that prescriber, to that dispenser. Does it make sense for the multiple prescribers, i.e., they're going to see an oncologist, they're also seeing an orthopedic surgeon, plus they have been to a dental surgeon. All of that one has to take into consideration. One also has to look at, on the mid-level practitioners, are their address of employment comparable to one of the physicians? Because then that would be considered a group practice. When I've ascertained that there seems to be a problem, that all the prescribers on that patient receive an unsolicited registered letter from us, indicating that they may wish to look more in depth at this patient. What we also did is, at the request of some of these practitioners, we made a modification to the patient monitoring program, that when the prescriber logs in to their account, any of their patients that have hit this criteria are listed. And it says the following individuals may be demonstrating some drug-seeking behavior. Some of the other activities that have been very voluntarily undertaken, the Academy of Family Practice Physicians has created a certificate program called the Safe Prescriber. they mandate additional training for their members. Plus, the member has to indicate that they are going to use the PMP routinely. To give you some idea of the roughly 18 million prescriptions, we're seeing approximately 13 million searches for those 18 million prescriptions. People are starting to use this as a clinical tool. Also, what was interesting initially, some of the lobbyists for some of the large box stores kind of fought us on what we were wanting to do with regard to tracking. But after a couple of them experienced some adverse activity and results of some lawsuits in Florida, they suddenly decided that they were going to mandate that all of their pharmacy staff had to use and would have access to the PMP, which gave us a little consternation because there's the first one that insisted, and we suddenly had to enroll all other pharmacists to be users. And then this was the second one that suddenly decided we're going to insist that at least on these 4 or 5 classes, they're going to have to run a report, print it out, and attach it to any prescription that they fill for that patient. This is the cumulative ongoing registration. These are the prescribers. This is the dispensers, the pharmacists. We're now sitting, even though it doesn't show it, we're sitting around 27,000 registered users, just about 28,000. We've been adding, as you can see, we've been adding at the rate of about 200 users a month. And what we do is, and I'll show you later in the talk, the website itself has the ability for the prescribers and for the dispensers to initiate their enrollment. They have to put down the method of contacting them, their email, their cell phone, their work phone, what their license number is. Our staff, and there's only 6 of us total, go in and validate with a direct line to TSPR. We search their data warehouse and check to make sure that the state controlled substance license is current, the practice license is current, and that there's no impending activity by the healthcare board against that practitioner. And then we contact the practitioner and give them their sign-on. This gives you a little idea of the Schedule II drugs from 2010 through 2014 as far as a completed year. What had us going very well is that 2012 to 2013, we actually showed 14,000 plus prescription reduction in the issuance of Schedule IIs. Until we get to 2014, and then all of a sudden it goes, whoa. Anybody have any idea why? Want to take a guess? What happened with hydrocodone in October? It went from a Schedule III to a Schedule II. Consequently, October, November, and December, you see a fairly large increase. Excuse me. With Schedules 3 through 5, from 2011 to 2012, we showed a reduction of 169,000 prescriptions. From 2012 to 2013, an additional 1 million plus reduction. Yes?
Could you me a favor for those of us who may not know what the different scheduled drugs are? Could you explain that?
Sure.
That would be super helpful. Thank you.
Schedule 2s are, well, Schedule 1 drugs have no clinical utilization. Heroin fits in Schedule 1. It also has a high propensity for dependency, both from a psychological and a physiological criteria. Schedule 2, there are clear clinical indications for the use of the medications, but they still have a very high propensity for misuse and dependency. 3s, less. 4s, even further. And then 5s, yeah, it's like, pseudoephedrine is there, and that's only there to track it. So that's the difference. And here again, October, November, December, significant change from the previous years. We saw a little bit of bump the 2 months before because everybody was trying to get on the bandwagon. They wanted to get their prescription for hydrocodone written with their 5 refills, so they have 6 months access.
Can I ask a question?
Sure.
The decrease between 13 and 14,
Mhm.
when that oxycodone moved, does not correlate to the increase at all.
No.
So there was something else at work there.
Yes. Called oversight. That's the graphics of what we just saw. Here's what's happening since the January of 2012 with regard to oxycodone, which was and is a Schedule 2, higher potency. And then this is hydrocodone. And if you notice, there is about a 400,000 prescription reduction total, regardless of whether it's in the 2s or the 3s. So we have seen a significant decrease. It's bounced up a little bit, but it's coming back down again. I think this eventually is going to sit somewhere around the 300,000 total prescriptions on a monthly basis. This is a report that I generate and share with our advisory committee. This section up here represents other states' PMPs that are looking at patients in Illinois, in the Illinois database system. This represents Illinois practitioners searching other states. Now, this is for me. This is what the web page looks like. And you can't go out on the internet and put in ILPMP. It'll take you to this website. And, well, thank you. I don't have to get my glasses changed. If you click on law enforcement, it will tell you the questions we want answered if you're going to request a report on an individual patient. I will counsel you to be very distinct in what you're asking for. Don't send us an email saying you want all controlled substances on all patients from all physicians at XYZ Pharmacy. Because I'm going to come back and ask you, what are you looking for? Because I have to, by statute and administrative rule, in my own mind, determine, is this a justifiable search? Not just a fishing trip. One agent kept calling me and saying, I've got to have all of this on this one pharmacy. And finally I said, look, I'm not going to give it to you. Tell me what you're looking for. Well, it's been reported that this pharmacy is dispensing pint bottles of Phenergan with codeine. Okay, that's one product in a very specific size. That's not all controlled substances. So what I did is I said, what we'll do is we'll run a report on all Phenergan with codeine dispensing from the time frame you asked for, and this way you can then look at the quantity of the sale and make your determination. So we give them the login. They normally have given us the password they want. There is a distinct line, and then there's an alphanumeric listing here, that when it is entered and they log in, we log it. So we know what day, what time, and who looked at what. I will point out that don't ask for, did that clinician look at the PMP at the time, at such and such a time on such and such a patient. The statute itself says no harm, no foul if you use it and somebody gets upset, or if you don't use it and somebody is looking over your shoulder to see what kind of practice you have. That's the way it reads current. And then prescriber registration, which is this next one. And basically, as I had said, it goes through what's the email address, what type of practice is it, so on and so forth. And it specifically gets down here and gives us the authority to track and to provide oversight. And it also indicates that the person that's registering acknowledges that they are providing a very specific clinical service to that individual. That's why they're looking them up. We've actually had to go in and lift some individuals' authorizations because I really didn't see how they could indicate that they needed to look up Obama, Oprah Winfrey. So, yeah, just the geographic area was too diverse. So that's also how we look at it. Once you are assigned all of this, they go ahead and put in the user ID, the password, that, and click login. Remember, this was for a prescriber. Patients with potential abuse indicators. And my staff have sense of humor. Bilbo Baggins. We're looking up Bilbo. It would be listed, and any other of their patients would be listed. And they could click on it, print it out, look at it. This basically says if you click on want to search a patient, that yes, I want to look at other states, and in this case, Sherlock Holmes. I have a slide. You can actually go in and request one, other than the current state, or we've modified it, and literally, you can go in and check off any and every one you want. We're currently working on a new program that will just say color states, so that all of the states actually accept Missouri, because it's the only state that doesn't have EMPs. And it would then come back and give you literally the ones that are in state and the ones that are out of state. These all say out of state. If you highlight the last name, gives you the detail, Sherlock Holmes, date of birth, where they live, Madison, Wisconsin, the drug information, what was picked up at that time, Strada Pharmacy, James Warren Harvey was the doctor, so yeah. So pretty much you've got quite a bit of data at your fingertips. At the request of some of our end users, some of the prescribers, they asked us if we would give them the mechanism for them to run their own report. Because a couple of doctors who had received the unsolicited registered mail from me called me back and said, those are not my patients. So here is one of the current weaknesses that we have. When pharmacies filling a prescription, most of the software programs have a point-and-click drop-down menu when you're looking for prescribing. And then you'll go down and look for James Jones. Well, as we all have found, anytime you're using a mouse and a point-and-click drop-down menu, just a twitch will take you to a totally different individual. And instead of the one doc that you're looking for, you get a totally different doc. And they take umbrage about being identified as having prescribed some of this stuff. So one of the things that we just finished accomplishing is on the May 8th Illinois Register, we passed two administrative rules from PMP that affect the Controlled Substance Act. One actually sets the mechanism that a clinician can register a complaint, we can evaluate it, and we can actually modify the file to correct an error. It also establishes the same criteria for a patient. Especially, we have been contacted on several occasions where the individual has said their identity has been stolen. So we designed a mechanism for that, and that is in the administrative. What is also interesting is that we had identified a deficiency relative to the dispensing of these controlled substances. The authority for mid-level practitioners, i.e. advanced practice nurses or physician's assistants, is predicated upon a collaborative or practice agreement or a collaborative supervisory agreement. Supervisory agreement is over physician's assistants. The collaborative agreement is for mid-level practitioners. Where if on Schedule II drugs, the physician that is granting this collaborative authority to prescribe has to clearly identify those drugs that they may prescribe. There was no easy method of finding that information out. So pharmacies were sticking their neck out and honoring those prescriptions. Well, under 77 Illinois Administrative Rule, Part 3100, that is a DFPR rule that was also passed in May. They have identified, DFPR has identified the PMP as the official repository for all collaborative practice agreements, so that pharmacies can go in, can identify, is this a valid prescription? And this way, the practitioner who is granted the authority will also be able to run a report to see what each of their collaborative practice partners have been prescribed. Kind of completing the audit trail. And this is just showing the selection on my prescriptions. And it would be considerably longer than that for most physicians. If you signed in and you want to look at PMP News, we actually provide updates on what's happening federally, what's happening statewide. We need to update it with regard to the fact that the administrative rules have changed. In fact, on the 30th, I've got an advisory committee meeting where we're actually going to be going through and identifying when everything starts or is initiated. How to contact us. Now, I gave a talk last year at the request of a heroin task force for Southern Illinois. And what we did is we attempted something that we've never attempted before, and it's very time consuming. So this is not readily available. We're going to work toward automating it. But we wanted to look at basically Interstate 70 South. So this, based upon the census population data, represents 1,252,566 out of the state population for 2013 of 12,882,000, or 9.7% of the population. I realize I've broken every rule on presentations. This is a lot of data. But if you look at the entire state for 2013, our county south of I-70, 12.5% of all of the Schedule II drugs were written, or 9.7% of the population. Depending on how one thinks about this and looks at it, what's the general method of earning a living in Southern Illinois? It is more labor intensive. Thus, these individuals have a greater propensity for injury and long-term debilitating disease. Three through 5, 2013, it's 14%. Okay, you still have to look at it. What was interesting when I did the original talk on electronic recording, I had a nurse who's the director of the pain clinic for Lord's Hospital in Paducah, came up to me and registered while we were doing the talk, well, actually after the talk, because over 50% of Lord's Hospital Pain Clinic in Paducah, their patients come from Southern Illinois. Which, when we started digging into some of the data, actually made sense, because some of the counties have no clinicians. They may not even have a pharmacy. So they're already traveling to another county to see a clinician. And we started to design some computer image programs that would also identify specialty practice and subspecialty practices We're still playing with those and evaluating those, but this is the type of evaluations that we're starting to do because House Bill 1 actually is going to require me to establish a peer review committee and to analyze clinical practice statewide. And it falls under a Research Studies Act. So we can actually intervene, we can ask for additional information from the charts, and we then, if we find something and the committee totally agrees that it is questionable practices, then we have to write an administrative rule that will allow us to notify the FDR and the Attorney General's office. For those of you who live in this county, this is a beta test that we developed. One of the drawbacks of using a PMP is the fact that the clinician or the clinical user has to remember another sign-in, another password, and are dependent upon the bandwidth of the area in which they're trying to seek that information relative to getting access in a timely manner. We did our own in-house test and found that it takes about 3 minutes to, from scratch, get on the website, get in, log in, and start. Anderson Hospital was part of a study with the PMPI, Prescription Monitoring Program Interconnect, that was going to look at seamless interface between electronic health records and the PMP. We met with them, and we have been operating since 2013. Their average utilization rate for searches between their 2 common care type clinics, remote clinics, as well as the emergency department, averaged about 207 searches a month. Now that we've done this interconnect, 5,344 is the current average per month. So what we're looking at doing is we have been reaching out in collaboration with the Illinois Hospital Association, with the Pharmacy Association, the medical societies, and we have another 9 sites that we are in the process of linking electronically. This is seamless. When they log into their EHR, they have the data there. That will significantly improve compliance. But it's interesting in your own backyard that they are that progressive. In 2014, this is what the White House issued as targets for opioid preventing drug use through educational programs, expanding access to treatment for those struggling with addiction, reforming the criminal justice system, the cycle of drug use, crime, incarceration, and reducing the stigma associated with substance use and support in recovery. Congratulations, everybody stayed awake. Nobody fell out of their seat. Any questions? Yes, ma'am.
I have a couple things, sorry. So do you have any idea of the percentage of Illinois prescribers that participate in the program? And then if so, I mean, is there a way to determine that percentage here in Madison County?
The answer is yes, but do I have it readily on my tongue? No, I don't. Remember, the number of prescribers and the dispensers shifts almost day to day. What we're pushing for right now is to being able to clearly pull all of the mid-level practitioners who are writing a large percentage of the controlled substance prescriptions with which doctors. Then encouraging those doctors to use the oversight program that we're developing so they can actually see what is being written to whom that is also attributed to them because they have granted the authority. And they, by statute, are responsible for at least sitting down and discussing every 30 days those patients for whom the mid-level practitioner has prescribed something. And evaluating the necessity if it is to be continued the following. So getting everything in line is imperative in order to come up with some very good oversight.
Absolutely. I mean, you guys are doing great work. I'm just wondering is it 20%? Is it, is it, so that we can have some idea, because then there's obviously a great number of people prescribing that we're not giving any information.
That's where we're working toward it, specifically as House Bill 1 moves forward. We're going to be responsible for establishing a peer review committee to do exactly that. To a degree, one of the last slides that I showed you where we compared statewide, here's the percentage kids, and then for the line of demarcation south, here's that percentage for this percentage of the population. The biggest problem with regard to looking at individual counties is the fact, as I said earlier, some of these counties have one clinician or two. In which case, it would be kind of like pointing a finger and saying, well, you're overprescribing. If you're the only prescriber in the whole county, you have to take that into consideration as you're evaluating the appropriateness. So I try to be very, very, very careful. The road to hell is paved with good intentions. I took it on the chin in '08 when we did away with allowing unlimited quantities of Schedule II drugs to be written with up to 5 refills. Even some of the supporters in the legislature. Do you know what you've done? You're costing me more money getting me my drug or my children's drugs because of the copay. Yeah, that was something we didn't take into consideration, and I'm still not inclined to change it.
I guess my question was because, as a group, we're trying to take a look at what can we do to be of support to folks who are trying to do good work. And is that, in this county, we hear from our U.S. attorney for the Southern District that, in our county alone in 2013, I forget what year the statistic was for, but there was just an exponential enough, Vicodin prescribed for 120 tablets for every man, woman, and child. So when we look at those kind of things,
I think that is going to change. Well, we're seeing a reduction of over 400,000 prescriptions per month. What is going to take its place? I have no idea. I'll be honest with you. I'm more concerned about the doping for academic performance with stimulants than I am heroin. It's growing at a significant rate. And it's Russian roulette because if the individual also then takes no-dose or takes an over-the-counter nutritional supplement that has a stimulant in it, it can lead to cardiac arrest and death. All of it is imperative that we look at sound utilization of medications. They are not innocuous. While they're designed to improve quality of life, they can also reduce the length of life. I would say and encourage the task force to look at supporting continuing education, or actually educational programs that start at the elementary level and go through the entire course of being freshmen in college. They have to understand that they are not indestructible. This is not an activity that they should consider because they're bored and they want a thrill. We also need to design educational programs for the parents and grandparents. Where do you store your drugs? How do you store your drugs? What quantities do you store them? We also need to look at developing viable mechanisms for drug take-back programs, because inevitably, because of pharmacy benefit managers, we're all encouraged to take larger quantities of drugs on our prescriptions, like 90-day supply. Well, that's fine if we know we're going to be on it forever. If it's something we're just trying, why get 90-day supply? You may not be able to withstand it. You may have side effects. Okay, that just sits in the medicine. Rainbow parties, which go back to when I was in pharmacy school, and I'm not going to tell you how long that was. But people would literally come in and throw a handful of pills or capsules into a bowl, and people would fish them out. Well, we're starting to see that happening again, where individuals will raid the medicine cabinet, they'll show up at a party, and they'll just kind of take a handful. To me, it's Russian roulette with 5 chambers loaded. Yes, sir.
One of the things that we see occasionally in the criminal courts is individuals using fake or false prescriptions to obtain prescriptions from pharmacies. You mentioned one example where you sent a registered letter to a doctor and the doctor's response was "not my patient," and you referenced human error in terms of entry of the data at the dispensing.
In that case, it was.
In that case, okay, but let's take that and just modify the example slightly and say, registered letter elicits a response from a doctor that says, "not my patient," and the data entered at the dispensary matches the prescription. Is there a mechanism currently to get that information to law enforcement from EMP or someone involved to law enforcement so that we can do an investigation of false or fake prescription?
One of the things that we're looking at is putting a hotkey in for the pharmacies, that if they identify something like this, that they can link it to the county sheriff's office, or, right now we're having the internal debate. Should it go to the county sheriff? Should it go to chief of police for that town? Should it go to Illinois State Police for their drug diversion task force? Should it go to the prosecuting attorney? We don't have a resolution on that yet, but one of the things we do have is we do link to the Sheriff's Association, the Illinois Sheriff's Association, and to DEA and to DFPR.
I have a question in regards to your comment that you made that some enhancement drugs, I guess, are concerned with college students. for study, etc.
Actually, it even starts in high school.
Okay. Are there particular ones, they're part of the task force has dealt with public schools, you know, I mean, advising and outreach, et cetera. What are the different enhancements? I mean, are these bodybuilding enhancement drugs, or these mental enhancement?
This is mental enhancement. Normally, it's the medication that one finds being prescribed for ADHD. Attention deficit. Yes.
Okay.
Or Adderall. And what has happened, and has been documented, is since it improves that individual's perception as far as being able to concentrate, other members of their peer group perceive that as an unfair advantage, to the point where some of these kids are offered money for some of their pills, and to ostensibly improve the ability to concentrate for a test. There's quite a bit of discussions about whether or not this is actually true or not, or is it just a psychologically perceived end. So, but to me, this is, again, our society's propensity to believe it's better living through chemistry. And that is a false. Yes?
If we suspect that a prescriber or dispenser is abusing the privilege, what do we as public do? Who do we contact? Is there a number of database?
Actually, what I would tell you to do is to write a letter to the FBR. They are responsible for licensing and oversight of prescribers and dispensers.
Will they connect in with you? Because you'll have information.
Oh, they are on my advisory committee.
If they connect.
Yeah. Yes.
Illinois has one of the better PAD programs, like as you tighten it up, I mean, there's unintended negative consequences to everything, so most people currently addicted are either going to seek help or switch to illicit drugs such as heroin. As you tighten up PDMP and start lowering my prescriptions, because you have a prescription drug problem, your cover time magazine is now beautiful. So as you're tightening it up, and these people are running out of prescriptions, ones that suffer from this disease, that need help or switching, all other resources can be put in place to pick up that negative consequence.
One of the things that we also did is that we put a link in so that practitioners, if they believe that they have a patient who is dependent on medication, they can actually click on their geographic area and find the closest drug treatment program for that particular class of drugs and do an electronic referral for that patient. And what you said with regard to the efficiency of our operation, I've had numerous people tell me I'm responsible for the increase in use of heroin. But all I can do is reduce the questionable prescribing of prescription meds.
Well, future generations will be spared from the surplus of prescription pain medication. But the current generation is moving towards heroin, and we see some dangers.
Right.
So the question is, these people, they need help. They need more tools to get into treatment and more tools to stay alive. So what can we do right now to provide that?
Well, one of the things that is in House Bill 1
Is that Blue Lane's bill?
House Bill 1.
Is that Blue Lane's bill?
Yeah, Blue Lane's bill. It passed the House 114 to 0. It passed the Senate 46 to 4 to 6. So we're waiting to see what's going to happen. It does lay out an agenda for increased training programs for the general population, for students, for parents, guardians, loved ones. It also establishes criteria for training programs for law enforcement with regard to proper utilization of naloxone. It does quite a bit. It also, excuse me, it also moves from every 7 days reporting by dispensers to PMP to daily. So we will be able to see the individual that starts, say, in Peoria, going to a number of walk-in clinics, then ends up in Bloomington, Norman, then in Lincoln, Illinois, then in Springfield, Litchfield, and down here. And we actually found patients like that. Did I answer your question?
There's an urgency. I work with heroin addicts. I have about 10 from Madison County, and we're waiting to get into treatment, and some of them are going to die before they get from the bed. So my urgency is now. Today, what can be done for these people? Gloucester, Mass has that great program, that they're the Angel program they just implemented, where you can come in and train yourself in and help you find treatment. And I got people that walk into Madison County Sheriff's Department and hand over their book and bricks to get them in treatment. It's not happening.
Well, and we are working with our fellow agency, NASA, Department of Alcohol and Substance Abuse. And, it's typical. The biggest issue is money, access to sufficient quantities, and establishing the base and then moving it out to all of the geographic regions of the state. I can tell you we are doing the very best we can as far as with the resources we have. Trying to design something that, number one, is useful and is realistic. Anybody else? Yes.
With regards to Missouri, kind of puts us in a little bit of a disadvantage. From your experience, they were close this year. Are they done before 2015? Is it something that they'll pick up? And if they do end up passing it, from your experience, how long does it take to set up where we can actually it's effective for it?
Missouri legislature is in session already. The bill died because of a Senate lockout last year. So we'll be this year. Or foreseeably next year. There may be a special session, as Nixon calls it, but that's highly unlikely that session may be called for Medicaid expansion.
Actually, we could do it, we could contract to do it on behalf of the state of Missouri. All the things that happen is the software programmers for most of the pharmacy software. The big box stores are already reporting to us on a weekly basis. All they have to do is just flick a switch and all the Missouri's could come to us. We can separate them with an identifier and with the same type of reports back to them.
I know you have a question.
Oh, I'm sorry.
That's okay. General public sometimes has concerns about all the move to electronic medical records and issues of privacy and hacking and so on. Can you speak to what security measures are being taken to protect patient privacy?
Well, it's a single portal system, so we will accept access one direction, and the individual can ask for one. That's also how we can identify when somebody's looking at Barack Obama or Oprah Winfrey, so that we actually do provide a mechanism to filter that down, and then periodically we do routine tests, having an outside firm try to sneak in the back door.
Maybe just one more question and then we have to wrap up our time here.
So in the pharmacy world, I have seen more of the prescription monitoring program used as a way to deny access for people. How, in your estimation, how do you feel that you said there's a link that prescribers and dispensers can click on to find treatment facilities if you feel that a patient does have a substance abuse problem? How often do you feel that that is being utilized?
That's an interesting question. I have not run a report to see how often that's been used. I will say that every time I have gone out and given a talk to any pharmacy association, medical society, and I've done numerous webinars on behalf of the PMP to actually all of the professional associations. We do consistently mention that the link is there, use it. You're welcome.
Randy, I want to thank you very much for your time and all the great information about PMP. Hopefully we've all learned some things. Maybe we've identified some things we can do better and encourage just enhancements of the program. But again, thank you very much for your time. You're welcome. Thank you to everyone for being here today and for your continued interest in working with us. I want to thank Ashley, Siri, Corey Myers, and just encourage everyone to make sure to make it out to see the Heroin Project documentary if you haven't yet, and encourage others as well. Thank you.